GLP-1 receptor agonists, medications like semaglutide, liraglutide, and lixisenatide, are best known for treating type 2 diabetes and supporting weight loss. But researchers are now exploring something unexpected. Could these same drugs also help protect joints in osteoarthritis and strengthen bones in osteoporosis? Welcome to Science My Health, your channel for health and research information. A 2025 review in Medicine examined how GLP-1 receptor agonists might affect both conditions. The idea is exciting because osteoarthritis and osteoporosis often occur together in older adults, and currently, no single medication effectively treats both. Why osteoarthritis and osteoporosis matter. Osteoarthritis, or OA, is a degenerative joint disease. It causes cartilage breakdown, inflammation, stiffness, and pain. By 2020, about 596 million people worldwide were living with OA. Osteoporosis, or OP, weakens bones and increases fracture risk. About 18% of people globally are affected, with higher rates in women. Both conditions reduce mobility and quality of life. So if one class of medication could influence both joint and bone health, it would represent a major shift. How GLP-1 drugs may help osteoarthritis. GLP-1 receptor agonists work by activating the GLP-1 receptor. While we often think of these receptors in the pancreas, they're also found in cartilage cells and joint tissue. In osteoarthritis, low-grade inflammation drives cartilage damage. In animal and lab studies, GLP-1 drugs such as liraglutide reduced inflammatory signals like TNF-alpha, IL-1 beta, and IL-6. They also improved key signaling pathways involved in inflammation. Beyond calming inflammation, these drugs appear to protect cartilage directly. In multiple experimental models, liraglutide lowered levels of enzymes that break down cartilage, like MMPs and ADAMTS, while increasing protective proteins such as collagen type 2 and aggrecan. In rat models of OA, treatment significantly reduced cartilage destruction. GLP-1 drugs have also shown antioxidant effects in cartilage cells, lowering oxidative stress, another contributor to joint damage. Do GLP-1 drugs reduce joint pain? Pain is the main symptom of osteoarthritis, and this is where the data becomes more mixed. Some animal studies found that liraglutide improved pain-related behaviors and reduced synovitis, which is inflammation of the joint lining. Clinical studies in people with knee OA and type 2 diabetes reported lower pain scores, reduced need for pain medications, and fewer knee surgeries among patients taking GLP-1 receptor agonists. A large trial of semaglutide also showed significant weight loss and reduced knee pain compared with placebo in people with obesity and knee OA. However, other studies found no clear improvement in knee pain despite weight loss. Researchers believe that some pain relief may come indirectly from reduced joint load due to weight loss or improved metabolism, rather than from a direct pain-blocking effect of the drug itself. So while pain improvement is possible, it's not guaranteed, and more research is needed. How GLP-1s may strengthen bones. Bone health depends on balance. Osteoblasts build bone. Osteoclasts break it down. GLP-1 receptors are present on both types of cells. In many animal models of osteoporosis, GLP-1 drugs increased bone mineral density and improved bone structure. Liraglutide, a GLP-1 receptor agonist, increased markers of bone formation and improved bone strength in several osteoporosis models. Semaglutide promoted bone-building signaling pathways like WNT/beta-catenin. Exenatide increased osteoblast activity and reduced sclerostin, a protein that normally limits bone formation. These drugs may also reduce bone breakdown. Several studies showed reduced osteoclast activity and changes in the OPG/RANKL system that favor less bone resorption. However, not all research agrees, and some evidence suggests bone density improvements may be driven more by increased formation than decreased breakdown. What about fracture risk? Fractures are the most serious consequence of osteoporosis. Some analyses suggest that certain GLP-1 receptor agonists, including liraglutide and lixisenatide, may reduce fracture risk, especially with longer treatment durations. Animal studies also show improved fracture healing and stronger bone repair. But other studies report no clear reduction in fracture risk, and some suggest possible increased risk with certain drugs. Differences in drug type, treatment duration, weight loss effects, and fall risk may explain the conflicting results. This research is promising, but it's still not definitive. There are limitations to the research on how GLP-1s impact bone health. Most of the supportive evidence comes from rodent models and laboratory studies. Human trials specifically designed to test GLP-1 receptor agonists for osteoarthritis or osteoporosis are still lacking or limited. GLP-1 receptor agonists are already widely used for diabetes and obesity. If future large clinical trials confirm benefits for osteoarthritis and osteoporosis, these drugs could potentially serve a dual purpose, helping metabolic health while also protecting joints and bones. For now, the findings are promising but early. More human research is needed before GLP-1 drugs can be recommended specifically for joint or bone disease. Like this video if you learned something new, and subscribe to Science My Health for more easy-to-understand health research news.